Right. Hello everyone. Let me just share my screen. Okay. Right. I just wanted to first of all say thank you very much for the opportunity to present to you this update on the diagnosis of motor neuron disease and or amyotrophic lateral sclerosis. My name is Nurtina Shahrizaila. I'm from University of Malaya in Kuala Lumpur, Malaysia, and I'm just going to go through with you um, mainly just to talk through the new diagnosis for MND ALS. I don't have any disclosures. So I think I wanted to just basically start off with by saying how, ALS, there are a lot of diagnostic challenges, mainly because it is a disease that's quite heterogeneous. So you can have patients, presenting with all sorts of clinical presentation. It does rely a lot on the history taking and examination, and really, it is then supported by tests. We know that there is a diagnostic delay, so that ranges between 10 to 16 months. And it's not just a motor syndrome, so it's not just about, investigating or finding somebody who's got motor weakness. It is also um, looking to see whether they have any other features. For instance, they can have cognitive impairment, they can have behavioral impairment, along with the motor weakness of dysphagia, dysarthria, respiratory insufficiency, and muscle weakness. So these are all features that you can see in a patient that presents with motor neuron disease, which is the reason why it becomes a little bit more complicated, because of the fact that, as I mentioned, it is not heterogeneous. It can be quite complex. So really taking away from that, the key points is that to make a diagnosis of MND or ALS is really more clinical than anything else. There is no definite test that you can do to say for sure. There's no one test to say for sure the patient has got MND. The history taking is important. And when we talk about neurophysiology, which is going to be the focus of my talk today, these tend to be more supportive, and they're supportive whenever you find that you cannot detect the clinical features that is obvious to suggest that there is motor neuron disease. So let's look back to what we know about the diagnostic for criteria for ALS. So if we go back to, back to 1994 and 1998 and 2008, so these were the criteria that perhaps, you're all really familiar with. And you will see here how, the criteria is really um, giving you probabilities of somebody having definite ALS, whether someone has probable ALS, whether somebody has possible ALS. And then the 1994 ALS scoring criteria also included suspected ALS. So when we look at that, essentially if we just look at saying somebody has clinical definite ALS, because really if you tell a patient, whether or not they have ALS or not, and you give them an option of definite, probable, possible, they're not really going to consider having possible or probable. They probably will think that there is still some hope. And really, we're talking about determining definite ALS. And how is that determined? If you use the ALS scoring criteria back in 1994 and later revised in 1998, you're having to demonstrate upper motor neuron and lower motor neuron signs being present in 3 out of 4 possible regions. So you have to demonstrate upper and lower motor neuron in at least bulbar upper limb axial or bulbar upper limb lower limb, upper limb axial lower limb. So, combination of at least 3 out of the 4 possible, and also demonstrating that the weakness is progressive. But in reality, it's that's not really the reality. To find that somebody has 3 out of 4, you'll find that by that stage, patients are already probably at pretty much end stage of MND or ALS. So in 2008, they looked at the criteria and felt that this could be updated, but they didn't really do much changes. All that was done with Awaji was to update the criteria for the low motor neuron involvement. And what they did was remove the probable laboratory supported category, but still kept the definite probable and possible changes. And looking specifically at the neurophysiology criteria, waves, there is white duration, big motor unit amplitudes, and also demonstrating that fasciculation on EMG was equivalent to having positive sharp waves and fibrillations, particularly when you see complex fasciculations, which suggests that the motor unit was unstable. That was a very important feature. So the ORG criteria basically added these two as being equivalent to physical examination and equivalent to positive sharp waves and fibrillations, especially when you put obvious, clinical fasciculation features. But limitations are there because the probabilities of that definite probable impossibility of these older criteria continues, remains. And that is very confusing for people living with ALS, as I've said before, because to them, saying that they've got probable or possible is not definite. And it's also a little bit more complex. It's complex because you then have to deal with probabilities. You then have to look to see, the EMG, having to demonstrate in, 2 regions, 3 regions, it just really adds to the complexity. And when you find that you do test, retest reliability, it's actually much lower when you're using these older criteria. And it doesn't consider the fact that, patients with ALS and MND, they have a spectrum of disease and they have different trajectories. We now recognize that patients who have a fast progressing disease, patients that have a slow progressing disease. And when it comes to basically looking at patients, each patient is very different in terms of how they present and how they progress. That is not taken into account in these diagnostic criteria. And also now things are different. There are newer biomarkers, and all of these really need to be considered, and they're not considered in the older criteria. And what it results is that making that diagnosis of ALS is delayed, that 10 to 16 months continue to persist when you're using these older criteria. And because of that, your patients are missing the opportunities to be included in clinical trials where they're trying to make sure that patients are included at the very, very early stages of MND or ALS to make a difference to the disease prognosis. So what I'm going to talk to you about today is really, how one uses the updated criteria. And this was proposed already. Now we're coming up to 5 years, almost 5 years of this being proposed. And the idea is that for all of us to be on the same page, for all of us to start really trying to incorporate this particular criteria and using it clinically to make that diagnosis of MND, ALS, just really so that patients can have some certainty so that you can make sure that they include in clinical trials, that treatment is started early, okay? And this criteria is also referred to as the Gold Coast criteria for the diagnosis of ALS MND. So the Gold Coast criteria essentially is a very clinical criteria. So what you need to do is A, the person is demonstrating, when they present to you, they're demonstrating a progressive motor neuron impairment, which you document as taking a history of a progressive motor weakness, and or when you do clinical evaluation, you find that the motor impairment is progressively getting weaker. And this is in somebody who, prior to presenting to you, is completely normal. So they had complete normal motor function, and now they're presenting to you with a progressive muscle or motor weakness. Okay? And you then demonstrate the presence of upper motor neuron and lower motor neuron dysfunction in at least one same body region, or a lower motor dysfunction only in at least two body region, and you exclude other potential disease mimics by investigations. So this is different to the previous criteria because we are no longer using 3 out of 4 regions. We're saying that at least one same body region, you are demonstrating upper motor neuron and lower motor neuron dysfunction, or lower motor neuron dysfunction in at least 2 body regions. Okay? The body regions remain the same. We're looking at cranial, i.e. the bulbar, we're looking at spinal, thoracic, lumbar regions. Okay? So essentially, rather than saying there is definite, probable, or possible, we're now saying, does this patient have MND? Yes or no? So no more probabilities. If they demonstrate presence of upper motor neuron and low motor neuron dysfunction in at least one single region, then the answer is yes. Okay, if they don't, then their answer is no. You will need to review the patients and decide whether or not they evolve. Okay, but at least what you can do is when they answer yes, these are patients that you can start already initiating potential therapy, putting them in clinical trials. Okay. So I'm now going to move on to the role of clinical neurophysiology in the diagnosis, because the focus of this is really to see how clinical neurophysiology can help. So the biggest use is that's incorporated, very, very clearly in making the diagnosis as well, is demonstrating low motor neuron findings. And this is helpful when you are not able to demonstrate clinically that there is apparent muscle wasting and weakness. Okay? But so you can't show the low motor neuron involvement. So what you do is that you then do electromyography, because evidence of chronic neurogenic changes plus active denervation changes. So we're talking about those changes I showed before, where you see big motor unit potentials, polyphasic units, you see active denervations, spontaneous activity of positive sharp waves, of fibrillations, of complex fasciculations. When you demonstrate that on EMG, even if the patient does not have muscle wasting or weakness, that already shows there is low motor neuron involvement. Okay? And also, one of the things that's been supportive is not considered as a must, but muscle ultrasound is now able to demonstrate or detect fasciculations, and these can demonstrate, a support low motor neuron findings whenever EMG is not able to demonstrate this. So other things in that clinical physiology is helpful is in demonstrating upper motor neuron findings. Okay, and how does it do that? First of all, in defining hyperreflexia. So how do we look for hyperreflexia? Typically, we would do the reflexes, right? We use a tendon hammer, we look for reflexes, but that can really be challenging, particularly when you have patients who have got a degree of muscle wasting that the reflexes are not that easy to elicit. Okay, so you then can't demonstrate hyperreflexia to show that there is also upper motor neuron involvement. So one of the ways of looking for this is by doing H reflex in muscles that do not normally have a H reflex at rest. So we're talking about not muscles like the soleus muscle, which is what we typically do, but we're talking about tibialis anterior, extensor carpi radialis, or abdominis brevis. And the picture that I show here is doing a H reflex in tibialis anterior. So typically, you can get a H reflex when you contract these muscles, but when they're at rest, it's very difficult to get a H reflex. You normally you're not usually able to demonstrate a H reflex. However, if at rest you can demonstrate a H reflex, that would suggest that there is hyperreflexia. And if you're able to do that, you then are able to now, using your physiology, demonstrate the finding of an upper motor neuron. And if you have low motor neuron in the same region, then you can say that this diagnosis is supportive of someone having MND ALS. Okay? So other ways of demonstrating upper motor neuron findings is to look for cortical involvement, okay? And you can do that with transcranial magnetic stimulation. So what am I talking about for that? So the one that is most comprehensive that you will see a lot of in the literature is using threshold tracking transcranial magnetic stimulation. And this is essentially, rather than just getting a motor evoked potential, which is your typical transcranial motor magnetic stimulation, what you do is you keep the actual motor evoked potential as fixed. And then what you do is you look to see how much stimulation is required to keep that that level of motor evoked potential, and that gives you an idea of cortical hyper excitability. Okay, and you find that the short interval intracortical inhibition, which is by utilizing a double impulse, that is reduced when there is evidence of cortical hyperexcitability. Other things that you can use, I mean, they're not as robust, would be to look at the cortical silent period duration, and also looking at the central motor conduction time, which is increased in patients who demonstrate evidence of cortical hyperexcitability. And these are features that would support upper motor neuron involvement. Okay. So other things that I said that are emerging that really ought to be, included moving forward, that was not perhaps so clear cut when they developed the LS Coriel and Awaji criteria, is things like imaging, for instance. Okay, so upper motor neuron involvement using magnetic resolution imaging, so MRI, with flare sequences, you can find that in some patients you will see increased cortical spinal tract and corpus callosum intensities. Okay, and then using DTI can detect cortical and subcortical atrophy. Using PET scan now, you can quantify brain metabolism and glial activation, and all of these are supportive of upper motor neuron involvement. And these are some of the emerging biomarkers looking at imaging. In the low motor neuron space, I already mentioned neuromuscular ultrasound. So looking at fasciculation is one way of doing it. But one of the things that you can do, and this is maybe looking at sort of like disease progression, you can look at muscle thickness, and that demonstrates when there is muscle atrophy. And you can also look at nerve ratios, where you will see that there are with nerve degeneration, you find that the nerve ratios are affected in patients with MND, ALS. Other things that you can do is also, using MRI, a bit more expensive. You can also look at MRI of the nerve and muscle. to demonstrate low motor neuron involvement. The nice thing about ultrasound is that you can use it, you can use it whilst patient sort of live capture. So you can use it with patient activating, whereas MRI is a little bit more difficult to do that. And of course, ultrasound is also very cheap. So these are things that, certainly can be used to support the diagnosis of ALS. So other things that, we now understand is using serum neurofilament light chain. So there is very good evidence to show that even before somebody is given the diagnosis of MND, we already see the damage in the nerves, and you can that is reflected by the serum neurofilament light chains rising. And then when they become very early symptomatic, it continues to rise, and you can use that as potentially as a biomarker. And later on, when the patients are already, definitely already have a disease, you find that the neurofilaments are stable and they continue to then remain stable. So it's probably not a great biomarker towards the end of the stage, but you can see that, pre-symptomatic and early symptomatic and later on established neurofilaments are definitely biomarkers that if you find it in a patient that have features of low motor neuron or even upper motor neuron, finding neurofilament light chains will be very supportive of the diagnosis being MND in the right clinical context. So in summary, the diagnosis of MND ALS really is one that is clinical. You want to be demonstrating that they've got progressive motor weakness when they were completely normal before they presented to you. And you want to demonstrate they have both upper and low motor neuron findings in at least one motor region. And that is either the cranial region, i.e. the bulbar, the cervical region, thoracic or lumbar region. And at the moment, there are no definitive tests that you can do. You can't, do one test that will say somebody has MND. It is a collection of clinical findings with supportive tests. Neurophysiology tests, as I've discussed, are supportive, especially when you cannot find clinical features that are obvious. Additionally, you want to be looking at muscle ultrasound, TMS, MRI, serum neurofilament light chains. These are all emerging to be very supportive when you have the clinical findings to make the diagnosis of MND ALS. And with that, I thank you and happy to take any questions.
بسم الله الرحمن الرحيم. طبعا يعني مرحب بحضراتكم في اول يوم، وشرف لينا طبعا احنا بنبقى مع حضراتكم في اول يوم CNC واول سيشن، ونشكر الساده اللي في ميعادهم، ونتمنى ان حضراتكم تكونوا استمتعتوا بالمحاضره بتاعت بروفيسور نورتينا شهرزاده. بروفيسور نورتينا online or not? Is Professor Nurtina online or not? No? She will join us afterwards. We are going to hear the other lecture from Professor Hatisi Tenkiti. She's from Denmark. She is going to talk about recent advances in diagnosis of Guillain-Barré. It's also a pre-recorded lecture.
Hello everyone. First of all, I would like to thank to the organizing committee and particularly Professor Faruk for this kind invitation. In my talk, I will try to give an update of electrodiagnosis of Guillain-Barré syndrome. As you all know, Guillain-Barré syndrome is an immune-mediated polyradicular neuropathy. Most prominent symptoms are muscle weakness and sensory disturbances. Patients may have difficulties in walking, and in severe cases, they may have paralysis, an important part of the standard workup. So in my talk, I will try to cover why electrodiagnostic testing is needed and when should we do the examination. Do we need to do a re-examination? And what are the typical findings? Do we need to do needle EMG? And I will also mention a few novel techniques in the diagnosis of GBS. So there have been several guidelines published on electrodiagnosis of GBS. This is an example from 2015 by Reja Bailey. In these guidelines, the focus was, of course, the diagnosis, but also differentiation of demyelination and axonal loss. So subtyping GBS as acute inflammatory demyelinating polyneuropathy, AIDP, or axonal GBS. And some limits have been recommended in these guidelines. This is not the main focus in the recent guidelines. Recent guidelines by European Academy of Neurology and Peripheral Nerve Society published in 2023. So my talk will focus on these guidelines. So in these guidelines, these are on diagnosis and also treatment of GBS, and electrodiagnosis has an important section in these guidelines. And the main purpose of electrodiagnostic studies in GBS in these guidelines is to support the early diagnosis of GBS. And as we all know, differential diagnosis may be a problem at the early stages, and there are disorders that may mimic GBS. So another purpose is the differential diagnosis of these disorders. And as I said, electrodiagnostic subtyping or classification into AIDP, MN, or MSN is not anymore the main focus, because no matter the subtype is, the treatment is the same. The management and the treatment is the same. This subtyping does not influence the treatment. So therefore, the main focus is early diagnosis. And for this, study changes may not be prominent. There may be slight changes, and demyelination or axonal loss may be difficult to differentiate in early stage. But as the focus is not this, in these guidelines, other polyneuropathies and radiculopathies, you can have absent age reflexes. And in these guidelines, facial nerve conduction studies and blink reflex studies are recommended as supportive tests. I must admit that in our lab, we are not doing these as a routine in GBS electrodiagnosis. So, the tests, the abnormalities that may be consistent with polyneuropathy, it may be motor nerve conduction study abnormalities, as you see here, or sensory nerve conduction study abnormalities, or FA abnormalities, either as absent F waves or prolonged FA latencies. Here you see absent age reflexes. As you know, for the age reflex studies, we are stimulating the tibial nerve at fossa poplitei and reporting from the soleus muscle. We are stimulating the nerve, starting with very low stimulus intensity. Then we get the age reflex. When we increase the stimulus intensity, age reflex will disappear and we get the M wave. Here you see the M wave, but there is no age reflex. So within the first week, the examination may be normal, but a normal electrodiagnostic examination does not exclude the GBS diagnosis. And in this case, a second examination may be helpful, but it is not crucial. If the clinical picture is evident, then there may not be need for another examination. And there are some features, either at the early stage or later, so in general, there are some features that support the GBS diagnosis. These are indirect discharges and prolonged distal CMAP duration, sural sparing pattern as we all know that this is characteristic for GBS diagnosis. And one point that we should remember is that the presence of age reflexes makes the GBS diagnosis quite unlikely. So here are some examples for indirect discharges. These are often multiple discharges and they resemble A waves, but they are not A waves, as you see here. And here there is absent F waves, but here you see again indirect discharges, but there are also F waves, prolonged F waves, 71.6 millisecond. And the indirect reflexes, indirect discharges are distinct from F waves. And here's an example for prolonged distal CMAP duration. So there is prolonged distal motor latency in the median nerve, and the amplitude is decreased, and the duration is 10.7, which is longer than 8.5, which is the suggested limit for this duration prolongation. And there is also reduced conduction velocity in the forearm. And here is another example. When the form of the CMAP is simple, it is easy to put the cursor for the duration. But if the CMAP form is not simple, then it may be difficult. So, but as a general rule, the cursor is put at the end of the main potential and before the positive deflection. And here the duration is 9.5, again longer than the suggested limit. But here you see also conduction block. There is a decrease in amplitude of 65%, which is definite conduction block. In these guidelines, the conduction block is not taken into account. I don't know why. And here another example, again, you see this is even a more complex potential, and it may be difficult to decide where to put the cursor, and and I chose to put here, but one can discuss here or here. So these are examples for serial sparing pattern. So there is a normal median nerve conduction study and ulnar nerve sensory conduction study. These are abnormal, but the serial nerve is normal. This is a characteristic for GBS, but one should remember that an abnormal serial nerve does not exclude the GBS diagnosis. So I just want to give some results from an ongoing study we are conducting. In this study, we included patients with inflammatory polyneuropathy, GBS, CIDP, and hereditary polyneuropathy, CMT type 1 patients, and we did serial nerve conduction studies using neonerve recordings. And when we look at the amplitudes in CIDP patients, the amplitude is decreased. In GBS, mostly normal, and in hereditary neuropathy, the amplitude is decreased. When we look at the conduction velocity, in CIDP, it is normal or slightly decreased. In GBS, mostly normal. Here you see the scatter plots. So in GBS, these patients have normal conduction velocity, but there are two patients with decreased conduction velocity. In hereditary neuropathy, the conduction velocity is decreased below 30 meter per second. Actually, with conduction velocity, we can distinguish hereditary neuropathy patients from inflammatory neuropathy. And here you see two examples. A patient with CIDP, there is normal conduction velocity, but decreased amplitude, so an axonal pattern. So this is very typical for CIDP. Although CIDP is a demyelinating polyneuropathy, serial nerve is often axonal. And in AIDP, there is a decreased conduction velocity and amplitude. The amplitude is 0.15 microvolt. We can report this because we used near technique. So with surface electrodes, it's not possible to report such a small amplitude. So what about needle EMG? Shall we do needle EMG? So I just want to show some results from another ongoing study. We included 30 patients with AIDP and 8 patients with MN, and we did EMG at the first week and the 4th week of symptom onset. And we did the EMG in several muscles. We are always doing quantitative evaluation, both the motor unit potential, but also spontaneous activity. How many sites there is spontaneous activity out of 10 sites. When we look at the first week in AIDP, FIPS and positive sharp waves, they are not very often seen, but in MN patients, in 20% of the muscles, there were FIPS and positive sharp waves. And at the 4th week, there is an increase in these, but mostly in MN patients. So using needle EMG, one can use it to differentiate between AIDP and MN and classification of GBS. So another point in these guidelines was acute CIDP. As you know, some patients with clinically suspected GBS do not clearly improve, and they continue to progress or relapse after 8 weeks, and then we get the suspicion of acute CIDP. And in these guidelines, there are some limits to suspect acute CIDP, where the reduction in motor neuron conduction velocity, if it is below 90% of lower limit of normal, or 85% if the distal CMAP is very small, and this is in favor of acute CIDP rather than GBS. And if there is the suspicion of acute CIDP, nerve ultrasound is recommended within 4 weeks. There is greater enlargement of peripheral nerves in acute CIDP compared with GBS. Otherwise, nerve MRI or nerve ultrasound are not recommended as routine add-on tests for the diagnosis of GBS with typical presentation. But if the presentation is atypical, these tests may be considered as in acute CIDP and for the differentiation between from GBS. So for the differentiation of acute CIDP and GBS, there is one study that I want to mention in which neuroexcitability testing is used. This, I don't know how many of you are have heard about these tests. These are, unfortunately, it's not possible to do it in using conventional EMG machines. You need a special setup. These tests are introduced by Professor Hugh Bostock from UK. What we are doing is to stimulate the nerve, like nerve conduction studies, and record from the muscle or finger, and we are using we are stimulating with current, and these are very similar to nerve conduction studies. Just the way stimulating and recording is different. With these tests, we can say something about whether the axonal membrane is depolarized or hyperpolarized, and we can say something about ion channels. And in this study, neuroexcitability testing could differentiate acute CIDP from AIDP in all patients. So this is a promising test that can be recommended for this differentiation, but the number of patients is quite low, even 4 for acute CIDP. So this is a study that should be replicated by other groups, but a promising test. So in conclusion, electrodiagnostic testing has important implications for the diagnosis of GBS. In the recent guidelines, examination within the first week is recommended, but the tests may be normal, but this does not exclude GBS diagnosis. In this case, a new examination may be needed. Needle EMG is useful for classification as AIDP or MN, and nerve ultrasound and some novel techniques such as neuroexcitability testing may be of help in atypical cases like differentiation of CIDP from GBS. So before I end, I want to remind you, ECCN in London now, abstract registration is open and abstract submission is open until the end of February. I look forward to seeing all of you in London in September. Thank you very much for your attention.
Thanks. Professor Hatisi is online. You hear us? She's online, I think. She's online. You can hear us? She's online. She can hear us? No? Okay, thank you, Professor Hatisi. Professor Hatisi is the professor of clinical neurophysiology here at Aarhus University, Denmark. She's the president of the EXCO, European Middle East Africa chapter of the IFCN, and she's the co-chair of the clinical neurophysiology panel of the European Academy of Neurology. Thank you very much.
Good morning, everybody. I would like first to thank the organizing committee for the wonderful